Good afternoon, students. Today we are going to start with the second part of screening of disease. Last day we have discussed on the definition of screening, what are the uses of screening, what are the purpose of the screening, and what are the differences between the screening test and the diagnostic test. We all know from the previous class that screening is done among inapparently symptomatic patients, that is the persons which are found to be apparently healthy. Today we have to learn to elaborate the criteria for the screening, to differentiate between the validity and the reliability. These are the two very important terms for the examination purpose, to discuss the components of validity. These are very important both for our theory classes as well as for the theory questions as well as for our practical, that is the Viva Voce, to define the gold standard test and to evaluate a screening test. Now we first go to the criteria for the screening. We all know that for any purpose we have to keep in mind the thing that is the ethics. Everything should follow the code of conduct, that is the ethics. Every screening program should have the ethical justification, scientific as well as the financial justification. Financial, it is very clear, that is the screening is meant to cut off our expenditure. So the criteria are based on the disease to be screened and tests to be applied. First, the criteria for the disease to be screened. The disease to be screened should be an important public health problem with significant burden of disease. We can take the example of our ongoing coronavirus outbreak. Here we are screening for the fever. It should have a long preclinical and early symptomatic stage. Natural history of disease. What is the natural history of the disease? That is the course a disease agent on getting introduced, it follows inside the host. That is, it may have the sign symptoms, may go to death, may have the natural recovery, everything may happen. And this should be clear for the disease to be screened. There should be the availability of the tests that can identify the disease before the onset of the sign symptoms. Availability of the facilities for the confirmation of the diagnosis. If it happens that we cannot confirm the diagnosis, if we cannot confirm the patient is having the fever or the cause of the condition, then there is nothing, that is the benefit of the screening. There should be the availability of the effective treatment. There should be an agreed on policy which should be uniform. Like I say that under our NPCTCS program, that is the program of for the non-communicable disease screening, we go for the screening of the hypertension. For hypertension, we have a uniform criteria. A person having the blood pressure more than 120/80, we can make that this patient is having at risk of getting hypertension. He may be hypertensive or having the chance of the hypertension. We have to, this is the agreed on policy. That is an uniform policy, has to be followed all over the world. There should be clear evidence that by the screening program, there is chance of reduction of mortality and morbidity at a very low cost. The main thing is the early diagnosis and thereby in a cost cutting manner. Now, criteria for the screening test. A screening test should be acceptable, because one thing that the person who are coming for the screening, they are coming voluntarily. I am interested to be screened for the service. But if beforehand we know that the diagnostic test or the screening test which I have to undergo is a invasive procedure, that is a painful condition, I must not go for that. So the acceptability is very important factor. Second thing is the repeatability. Repeatability in what sense? That is, I am measuring the blood pressure of a person now and I am measuring the blood pressure of the same person after 1 hour, there will be variation. This is the intraperson variability, and another one is the interperson variability. That is, I am measuring the BP of person A and you are also measuring the BP. There will be some difference. And another thing is the biological variation. You all have heard, that is the diurnal variation. Some parameters are there inside the human body, like as the serum cortisol level, like as your blood pressure. It shows some diurnal variation. Some measurement that is taken at morning, the difference is there at the evening time. Validity, we will discuss it in details. Rapidity, ease of administration, it should be easy to administer, it will be safe, and of course cost effective. Now we are going for the two important terms, that is validity and reliability. Validity is the accuracy of a test. What is accuracy? That is how close the result of the test to its true value. I have measured the fasting blood sugar of a patient, that is 129. How close it is to the standard fasting blood sugar? Only 3 or 4 units variation is there. So we can tell it is valid. And another term is the reliability. We all are very used to with the term, that is the reliability. How reliable this person is. That is the precision of the test. What is the meaning of the precision? That is how close the results of a test are on repetition for several times. We have measured the fasting blood sugar, or say fasting blood sugar, we have measured 10 times, and the values are within a specific range, that is between 123 to 133. So we can say that these are repeating several times. We can say that it is precise. Reliability or repeatability is there. So we have come to know the two terms here now. Validity, that is the accuracy, closeness to the true value, and the reliability, that is the precision, that is the repeatability. On repeated time measuring, the closer values are coming. Now the validity, it is very important for the examination purpose. Validity has two components. First is the sensitivity. Sensitivity means what? True positive. Sensitivity is true positive. It is a very common MCQ. What is sensitivity? True positive, true negative, false positive, false negative. 4 options come and we have to take the true positive one. Now what is true positive? That is the ability of a test to identify correctly among all those who have the disease. Say 100 people have come to me. I have a diagnostic test, and by this we can find out that among these 100, 70 are having the disease. So this 70% is the sensitivity of this particular test. It is the true positive. Here we are giving the example, that is 80% sensitivity. That is 80% chance of detecting the true positive. That is the person actually having the disease condition out of the total people. Similarly, another one thing, that is the specificity. Specificity means that is the true negatives. It is the ability of a test to identify correctly all those who do not have the disease. Here we can take the example 75% specificity. If a test is having the 75% specificity, we can say that the test can identify 75% true negatives who are truly negative, do not have the disease, who all are negative found by the test, and rest 25%, who are they? They are false negative. They are falsely negative. That means they may be truly positive. Now the thing come, you have probably have heard this term, that is the gold standard test. Gold standard test, it is the benchmark. The results of the gold standard tests are definitive, final thing. That is, I am telling this is the gold standard test. By this gold standard test, what is diagnosed? It is the full and final. Like as for the cancer, biopsy is the gold standard test. Similarly, for the cause of death, you are now reading, that is what is called postmortem, autopsy. It is the gold standard test for the cause of death. For infection, say a person is having the urinary tract infection, we are going for the culture sensitivity. And this culture sensitivity, it is the culture is done for the definitive diagnostic. It is the gold standard, and sensitivity to see to which antimicrobials these organisms are sensitive. Similarly, for the any septicemia, sepsis, we go for the blood culture. So these are the benchmark, definitive test, ultimate test. See, for a screening test, these are the groups of people. Group A, they are true positive. They are having the disease and test positive. Test finds these people positive and these persons are having the disease. These are the group A people. Group B people, test have found them positive, but among them the disease is not there. So they are false positive. Simple it is. Falsely positive. Falsely positive, that means they may be truly negative. Maybe. May not be also. Similarly, the group C. See here the row heading, that is the test negative. That is test find this group of the people as negative. But these patients are having the disease. Disease present. See the column head, disease present. So these patients are false negative, falsely negative. They may be truly positive. Persons are having the disease, but the test cannot find it. And group D, that is true negative. Person is not having the disease, test is also not getting the person having the disease. So the true positive, person having the disease, test find it positive. True negative, test negative, group D. That is true positive and true negative. True positive is person having the disease, test finds it positive. True negative, that is the group D patients, patient don't having the disease, test is also indicating the person not having the disease. Group B, false positive. Person is not having the disease, but test gets that person is positive. And group C is the false negative. That is person is having the disease, but test find it as the negative, falsely negative. Now evaluation of the test, how can you calculate the sensitivity specificity? Sensitivity is A by A plus C. From the previous one you can see A means that is the true positive. True positive divided by true positive plus false negative. That is the total disease present patients. That is disease present patients are here the denominator. True positive divided by the true positive plus false negative into 100. Similarly, the specificity is D by B plus D. That is the true negative divided by true negative plus false positive. That is the disease absent. I have already told that the false positive, that is falsely positive, may be truly negative. That is the disease absent. This is here the denominator. How can we calculate the percentage of the false negatives? That is C by A plus C. False negative. False negative is here the numerator. And denominator are the all disease present patients. And the percentage of the false positives, B by B plus D. That is false positive divided by the total disease absent patients into 100. Now we are going to another very important thing. That is the predictive accuracy of a screening test. It very often comes in your examination and in the MCQs for the post-graduation entrance. Predictive accuracy reflects the diagnostic power of a test, and it depends upon three factors: sensitivity, that is the true positive; specificity, that is the true negative; and disease prevalence. What is disease prevalence? Total cases, new plus old. There are two predictive accuracy values. One is the positive predictive value of a test, another one is the negative predictive value of a test. Positive predictive value PPV is the probability that a person with a positive test result actually having the disease. This is the ability of a test to find out the actual positive patients, the persons who are actually having the disease, out of all test positive cases. Similarly, the negative predictive value of a test indicates the probability that a patient with negative test result actually who do not have the disease. So the positive predictive value is the ability of a test to detect the actual diseased patient out of all positives, all positive cases, and negative predictive value is the ability of a test to detect the non-diseased patient among the all negative patients. Now, how to calculate the PPV and NPV? PPV can be calculated by the A by A plus B, that is true positive divided by all positives. True positive divided by true positive plus false positive, that is out of all positive cases who are actually having the disease. That is the true positive is the sensitivity, that is actually who are the positive. It comes in the numerator, and in the denominator all positives, all test positives into 100. Similarly, the negative predictive value is the D by C plus D, that is the true negative, that is our specificity, divided by all test negatives. This is, I know that it is not very clear to most of you. We will discuss and we will have the actual example. We will use this in our practical classes. Now you go through these lectures and you please go through the books. We have the Park book, and you go through this 1 or 2 pages. You will have at least a bit clear idea. Now you have assignment of marks 10. Write short notes, any two. Difference between the screening test and diagnostic test. Late time. Hope you have remembered the late time. This is the time advantage. I am just giving you one single line, but you have to write it 3 marks out of for the 3 marks. That is the time advantages obtained by screening test over the diagnostic test. And third, the criteria of the screening test. Among these 3, you have to write 2. And here are the 4 multiple choice questions. Which of the following tests is a screening test? Screening is done for whom? What is the sensitivity means? There are 4 options. You have to choose only one. And positive predictive value can be calculated by the following formula. You have to choose one. So, submit this assignment within next week, that is by the 31st March. Next week, next Tuesday. Be safe at this crucial time. Stay healthy now and always. Thank you.